Today guys, another busy day in the office. Thursday seems to bring in some clinical pearls all the time, doesn't disappoint. So here's an interesting case I wanted to jump on here and discuss. I had a patient who was complaining of right hamstring pain, like pain around that hamstring area, and the diagnosis or the referral said right tendinopathy, hamstring tendinopathy. But the thing is, he reported that he wasn't really active in the last couple of months. In fact, his majority of his pain was coming when he was sitting or driving. Now that doesn't sound like a tendinopathy, especially when you don't know what started it, and he had no idea what started this pain. So I was thinking of maybe this could be something else. As we did the range of motion, he fit in the classic pattern that we always find, which is basically when you have any kind of lower leg or lower quarter symptoms, I find that the ipsilateral range of motion is restricted, and I check for. So coming back, if you have any patient who presents lower quarter symptoms, it could be, let's say, right side or any side, hip pain, ITB pain, knee pain, pain going into the calf, plantar fasciitis, pain in the groin, any of these symptoms where, again, the history or the subjective history doesn't add up with like a tendon related problem, you definitely want to try and check for side glide, ipsilateral side glide and standing, or you want to check for side flexion on that side. If you find that the side glide and standing on that side is restricted, most likely resolving that with some other movements can start to centralize the symptoms of that leg. Again, if you have any questions about what that looks like, I'm going to make another post on how I check for side flexion, not side bending, but side glide and standing. Hope you have a great. Hey, what's up guys? Happy Thursday. So I have one clinical tip and one question that I wanted to ask you guys. So the clinical tip is, I had a patient who came in with lateral shoulder pain, especially in the painful arc, which is roughly about 60 degrees to 120 degrees. But when I was taking the history, she did not respond. She did not tell me of any provocative activity or anything that she may have done to trigger this pain, any increased activity levels or exercises. She was basically kind of living a sedentary lifestyle because of COVID and all those things. So oftentimes when somebody comes in with lateral shoulder pain, we are often thinking of a shoulder problem, but I would urge you to also think of neural tension. And that's something I see a lot of times. People do miss. I've missed it myself a lot of times, but that does not sound like a shoulder problem. So anytime that happens, do suspect the cervical spine around the C5 section, right, which supplies the side. So you want to try and release that either by whatever means you like. You could dry needle, you could rub it, IASTM, repeated motions to the side, whatever you do, just make sure you don't rule out the C5, work on that and see if the painful arc gets any better. If it does, then you know it's not exactly the shoulder, but mostly the neurotension. Hey, what's up? Happy Friday, everyone. I'm back at Westboro today, and I had an interesting case which kind of ties up with the last Instagram story about painful arc that we were speaking about. So I had a patient who complained of heel pain in the last 2 months, especially when she's trying to dorsiflex her foot. She feels a pain at the heel, and then when she tries to squeeze it, but that's only during dorsiflexion. Not a lot of pain during walking. Also, in the last 2 months, her activity levels have basically been the minimum. She used to be a runner before, but she hasn't run in a while, and basically the last 2 or 3 months have been really stressful. 8+9+ hours of working on a computer all day and basically bare minimum exercises. So does that seem like a plantar fascia or a heel spur pain to you, or could that be a possible S1, S2 sensitization? By the way, we tried a bunch of like back stuff, posterior pelvic tilts, lumbar rocking, side glide and standing, and her asterisk signs, which was tender on the calcaneus while doing dorsiflexion, got better. So again, something to think about. Don't jump to plantar fascia, get the history and see if it could be a possible nerve root irritation as well. Have a good weekend. Hey, what's up guys? Abhijit Minhas here. So I took some time off and I was traveling, and I'm finally back in the office. And so my plan is to start to make these videos again, where I kind of go through my workday and see if there's anything that seems to bring in some value to physiotherapy practice and present that to you. So I had an interesting case today. Basically, I had a patient who was like in her mid-60s, female patient, with the diagnosis by her doctor, or the referral said costochondritis. So basically, she had pain right at her sternum, right at the bone, and every once in a while she would also feel like she had pain kind of going back towards her mid-back section, but that would only happen sometimes. Majority of the times she would have discomfort and pain right here. Initially she thought it was a heart problem. She's getting acid reflux stuff tested, and she's all good with that, but she still has that pain. So I wanted to take a second to discuss this. Now, there are many things that you can do for costochondritis, or somebody who comes in with a fancy diagnosis like that. But the things that I really like, and again, my intention with these posts is to give you these little hacks or clinical pearls that can make your life in the clinic a bit easier. So here's my we have learned this in the past, that we may mobilize the ribs by doing like some rib kind of mobilization, maybe release some of the soft tissues here. But as you can know, like especially if it's women, that would be a sensitive area to work on if you're trying to release the pecs. What I rather do is I target my focus on mobilizing the mid back. And in the mid back, I'm especially concerned about extension and rotation, but rotation more than extension. So I use the classic exercise, which I laying on the floor, legs on the ball, and I would gently move the ball side to side just to increase some overall trunk flexibility. And if you go nice and slow with that, you will realize that generally your patients will start to get a bit better, hopefully. Of course, you want to rule out all red flags and stuff like that, but give that a shot. The link to one of those exercises should be right up here somewhere. So hit that, take a look at that exercise. But the simple rules would be, of course, rule out any red flags. Make sure this is a musculoskeletal problem, and then be as gentle as possible and don't provoke symptoms, and try some thoracic mobility exercises. It doesn't have to be this one exercise, it could be anything, but I find this one to be the easiest. So give it a shot. Let me know what you think. Have a good one. Happy Wednesday, everyone. I just wanted to do a quick recap for yesterday, which I was unable to do because I was kind of busy. So I had an interesting assessment last week when I had a patient who came in with a sudden onset of left shoulder pain with some tingling and burning down the left arm and inability to move the arm at all. Upon taking further history, I found out that the onset was sudden. So the past weekend, he went to bed, and the next day when he woke up, he had intense pain in his shoulder and he could not move his arm. Of course, that was very disconcerting. So he went to the emergency and saw the doctor there, and the doctor was after doing his examination, told him that he had a frozen shoulder, and the doctor was kind of surprised on how quickly frozen shoulder symptoms developed, and told him that this was very unusual and sent him for physiotherapy. Now, I did tell the patient that I kind of agreed with the doctor on the sudden onset of symptoms were slightly confusing and did not match with what we generally see with frozen shoulder. So in my own examination, the pertinent findings were decreased reflexes in the arm, the bicep reflex, the tricep reflex, they were all diminished. Basically, now that I'd seen him after a few days, the symptoms were a bit better. But the classic sign again was that his passive range of motion was complete and active was really restricted, roughly about 30 to 40 degrees in flexion, likewise in abduction. So basically, I gave him some really easy exercises, told him that most likely this was not frozen shoulder, and actually what these symptoms mimicked was some kind of a lower motor neuron compression, like a Saturday night palsy, where he was sleeping in a position which caused a temporary So now fast forwarding to yesterday, which was his first follow-up appointment, he came back and he had full range of motion, no pain, slight tingling in his in the anterior part of his left shoulder and slightly behind. Reflexes seemed to be much better, and he had full range of motion and did not have any episode of pain, slight discomfort, but that's about it. The numbness had gotten much better. So overall, this kind of confirmed the fact that he probably sustained some kind of a compression neuropathy, which as we know, is like a grade 1 in nerve injury, which is a temporary compression. And as that compression or that provocative pressure is released, like the nerve starts to conduct again. So again, something to think about when it's a frozen shoulder. We always checking active range of motion versus passive range of motion. I know I've said it a bunch of times, but I think this message has to be said again. So have a great rest of the day. Hey, what's up, everyone? So, I had a few of you reach out to me asking what kind of stretches I was doing for my patients with the previous stories. And basically, I don't really do a lot of stretches to regain mobility for my patients. Like I said before, I rather focus on some PNF and some hold, relax, and those kind of techniques and active movements to regain mobility rather than doing a pec stretch. So, here's an example. I haven't really warmed up much. To show you the ability of me to my ability to bring the stick back as far as I can. And here it's not really smooth. I feel a big stretch through the pec. If I really force myself, after getting a lot of tweaks in my shoulder, I get back. And then as I start to go up, I feel a tremendous pressure through the back of my shoulders and down here. Now, I have seen a few patients. Imagine if you have an injury, that could be even worse, right? So classic stretches that somebody may give, just because that seems like that's a pec motion, is the classic pec stretch and the door frame stretch. However, what I rather do is, but imagine if you have an injury, that could be even worse, right? So classic stretches that somebody may give, just because that seems like that's a pec motion, is the classic pec stretch and the door frame stretch. However, what I rather do is, I'm going to grab some kettlebells here, right? And then I'm going to hold them. So right now, as I'm holding them, I'm co-contracting, like there's an isometric contraction of muscles in my shoulder, my rotator cuff, and from here, from an isometric hold, I'll start to do some protractions, retractions, a couple of repetitions there. I'll do some shrugs and some gentle, now kind of let go of the weight, right? So basically I engage my muscles isometrically and then I have them move a little bit under tension. Now I give myself a few seconds to recheck that motion again to see if I've regained any range of motion. So same drill again, right? And this is a breeze for me now. Like I do anything, I probably feel a little stretch in my right pec, and that's only because I did only a few seconds. If I did longer, I won't even feel that anymore. Now, some of you, I have posted this before, and some of you suggested that I'd be honest with this and I'd already stretched. So if you feel that's the case, I urge you to try this on your own and see how you feel, right? All you got to do is try your mobility initially, see how you feel, then hold some weights, repeat this process. Excellent responses on the question I asked about how do you determine what are the criteria for assessing or diagnosing somebody with a frozen shoulder. So hopefully some of those answers help. I do use a lot of that information that you saw in those stories to the person has a frozen shoulder. But having said that, here are my top criteria or factors that I'm looking for. So number one, planar loss of motion. So a bunch of motions would be restricted, but the primary one is, and we often compare all these motions to the opposite, the unaffected side. So in external rotation, if you see about 50% in loss of or deficit in range of motion compared to the unaffected side, and any other two ranges of motion, 25% deficit compared to the other side. Now, if you follow the capsular pattern, that could be internal rotation, which I tend to find a lot, abduction, and then followed by flexion and extension. One criteria. The number two criteria that I often use is that active range of motion is generally equal to passive range of motion. So basically the patient would not be able to lift their arm up, but you cannot do it also. So those would be the two main criteria. Now there were a bunch of risks in the stories, and all those risk factors are really important, and they do give us a bit of an insight into that, into the condition. But just know that, for example, a rotator cuff problem and somebody having a history of diabetes or any other cardiovascular to have some kind of rotator cuff tendinopathy, and they'll put them at a risk of that. So while those factors are important, but those risk factors, but they're not the ones that you'll help to that you should be using to make a. But it should definitely give you a bit of an insight into what's going on with this frozen shoulder. So hopefully that information helps. Hey, what's up, guys? Clinical recap for Wednesday. So I have 3 assessments today, and out of those 3, I already saw one of them. Really interesting learning experience for me. So one of my patients she was actually from last December when I saw her for some lower quarter symptoms, which I believed were coming from her back. So we worked a bit on her back. Her leg symptoms started to get better, and on her sixth visit, and I remember it like yesterday, exercise lumbar rotation on the ball, and as I was gently kind of guiding her through and moving her to the side, she felt a sharp spasm through her back. She got up and I checked, nothing seemed wrong apart from maybe a little bit. I offered her a heating pad, she refused, and she just wanted to head home. So I followed up with her, she didn't really reply back, and then after that I didn't see her. So unfortunately I didn't see that she was in for her back, and her back never got better after that incident, which is about 6 months, to a point where she felt like she probably had a fracture in one of her ribs, and she went to the emerge there, like there was no fracture, and the doctor said it was a muscle spasm and she had to go back to physiotherapy. Now, having said that, it's almost like a learning experience for me, because I always tend to lean towards gentle exercise, convince her to do any kind of active-based movement exercises just because of her apprehension and kinesiophobia. So I had to do some manual therapy. I had to work on releasing some muscles. Well, I say releasing, you know, we're not really releasing some muscles, and she felt a bit better after that. So that was a bit of my buy-in, which people hate to hear, but hey, sometimes we use it. So if we know why we use manual therapy, at least I know why I use manual therapy. As long as it's a treatment, it's not the only treatment, I think there is nothing wrong with it. So finally, clinical tips so far are: number one, gentle is better. I keep telling myself all the time, and manual therapy is not the devil. Hope you have a great day, and I'll recap again to see if there's anything more interesting for today. Have a good one.